Good morning, everyone. My name is Jenna Angelillo, and I'm the Director of Marketing and Communications at Concierge Choice Physicians. And I'm happy to welcome you to our panel discussion today, Inside the Shift to Concierge Medicine, Lessons from Health System Leaders. So at Concierge Choice Physicians, we've been working with doctors, large medical groups, and health systems for more than 20 years, helping them develop, launch, and grow their concierge programs. And this has been a busy time for us. There are many challenges in healthcare, the healthcare marketplace has experienced, and this has led many leaders in health systems to reach out to us and take a fresh look at concierge medicine. So I'm very pleased to be here today with two of our colleagues, our clients, who have concierge programs in their health systems. And they're going to talk to you a little bit about their programs, how they got started, how they grew their programs, and how their programs are working right now, and how they are working to address some of the challenges that we're all facing, like revenue challenges, physician satisfaction, and physician recruitment and retention issues, and of course, patient satisfaction. So I'm just going to ask a few questions just to frame the discussion, and in the end, we'll have time for questions from the audience as well. So let me get started introducing our panelists. Our first panelist here is Tim Seibert. Tim is the Chief Administrative Officer and the Executive Director for the Primary Care Initiative for Weill Cornell Medicine in New York, New York. Welcome, Tim.
Thank you.
And we have Dr. Chad Waddell. Dr. Waddell is the Site Director, Internal Medicine member, and he's on the Board of Directors of Mission Heritage Medical Group and Mission Hospital Foundation in Mission Viejo, California. And Dr. Waddell brings a dual perspective because he is not only a business leader in his organization, but he's also a practicing physician with a Concierge Choice program. And at the end, we have Keith Elgart, who is the Concierge Choice Physicians CEO, and he'll be able to speak a little bit about any technical questions or insider questions that you may have. So let me get started with just some basic questions. Concierge medicine means so many different things to different people. So I'm going to ask our panelists to just describe a little bit about how concierge medicine fits into their health system. So we'll start with Tim.
Sure. For us at Weill Cornell Medicine, concierge medicine was an opportunity to provide our community with sort of another type of practice. We have a lot of our facilities on the Upper East Side of Manhattan. Patients had been requesting concierge medicine for a long time, which seems to make it sound like it was easy for us. It sort of was. And so we introduced it with 5 physicians as a pilot. It was extremely successful. And then about a year later, we added maybe 10 or 12 additional physicians. Today, we're 3 years in, and we have 19 internists and 1 cardiologist doing it. I have 2 internists that will be doing it come May, and we're going to pilot a pediatric program come July 1. Really, it was quite easy to do.
Dr. Waddell?
We looked at how we could serve our community in the sense of, could we meet patients at all the gates in which they were coming into the organization? Obviously we have insured patients, managed care patients, and we were looking at how could we attract all the patients. Now, the area that I'm in is in Orange County, which is a suburb of Los Angeles. And we had a lot of, as Tim was saying, a lot of patient interest in doing something like this, as well as it was really a physician interest. So about 5 years ago, we started our program with a pilot program of 5 physicians in internal medicine. That has subsequently expanded almost double in the last several years. How it fits, what we do is we do a hybrid model. We really wanted to not have the physicians lose their panels because we felt that was important to the organization, but we also wanted to be able to generate revenue that we weren't able to see. As most of you in this room know, primary care is usually a loss leader, right? It's an investment in the foundation of the medical practice that leads to referrals, that leads to procedures, and yada yada. That downwind do well for the organization. So concierge medicine was a way for the physicians to make a little bit of extra income and also for the organization. Currently, we have a hybrid practice, and that we do cap the number of concierge patients because to be able to manage both the concierge piece and the panel piece, you have to have a balance in that. It's probably more than you expect. It's about 150 in our organization is where we usually cap at. And we are able to integrate it by having hold spots in the morning and in the afternoon of our panel sessions. And if these sessions aren't used by concierge, which in many times it's not, that enables us to have access for our other impaneled patients. It's working well. The physicians, when we look at their engagements in respect to burnout, which is another thing that's happening across medicine, we have seen actually an increase because I think concierge medicine gives an opportunity for physicians to get back to kind of the Marcus Welby way of giving medicine, right? I mean, a lot of medicine's been so compartmentalized and checkbox and AWVs and all the other things that you go through. And concierge medicine gets back to the core and allows you to spend more time with the patient, so I see more satisfaction.
So can you tell us a little bit about how you achieved buy-in from your organization when you launched it?
Yes. So lots of meetings. When we started out, it was first off, it came from the physician side. A lot of physicians were asking me within the department, can we do this? Can we do this? And obviously we're in a large healthcare organization, so there had to be many meetings and discernment over it. I think the biggest concern was the reflection in the community of, are we, doing tier-based medicine? And in reality, I was able to go back to kind of how our organization started, which was back in the 1600s, started by the sisters. And I remember having to go through a formation class when I was in leadership training. And part of that story was that the sisters at night, they would care for the patients during the day, but at night they would make lace, and the lace was for those who could afford it, obviously. But they used those funds to give back to the community. So how I was able to integrate it was, one is that we were going to give a portion of the fees that we collected back to the community for community benefit, and that'd be the entire community. And that's kind of in the spirit of what we were doing. So I was able to get buy-in there. From the physician side, I had to get buy-in in the sense of, I think there was initial fear of how many calls would I get? Would I be woken up at 2 a.m.? As I've told Keith and Tim, the concierge patients are very, very, very respectful of your time. They do not call you. They will wait till 8:01.
That's almost too much.
Yeah. And
So
yeah.
it is curious that you bring that up, though, because my next question was about physician satisfaction and how their concierge programs can lead to enhanced physician satisfaction and even physician recruitment and retention. And that's a question I really want to direct to you, Tim.
Sure. So I'll just touch quickly on our introduction. It was not easy as well, and we had to sell it. It's an academic medical center, and we had to sell it not only to the physician organization, but to the hospital and to the community. And we did get some pushback specifically from physicians in the community that actually had out-of-network practices. So they were concerned that we were going to have a two-tiered system when they themselves were having an outpatient patient practice. So it was very interesting. So for us, we have retained a good portion of our physicians. We were able to secure a group of physicians, 3 senior physicians from one of our competitors, because they reached out to Keith to talk about doing concierge medicine. That institution refused those physicians who were with them for a very long time to explore concierge medicine, and Keith introduced them to myself and our chief medical officer. They are incredible hires. They're with us now, I think, going on 3 years. All 3 of them do a hybrid model up until February, where one of them, which was the plan, has transitioned to a full concierge model. It's going really well as well.
Okay.
Oh, let me just say one other thing I should say. So during this time period, I would say during the past 5 years, we have lost a total of 6 physicians to the full concierge competitors, if you will. 1 pediatrician and 5 internists. And so for us, again, it was about patient, demand and retention, but also physician recruitment and retention, because New York City is a hot market for concierge medicine.
I would agree with the recruitment and retention issue. As many of you in this audience are probably well aware, it's very difficult to get primary care doctors these days. Most of them go into a hospitalist track if they are doing internal medicine alone, on at least the internal medicine side. So really the numbers that we have to recruit from each graduating residency class are low. So you have to have that extra factor. I've had several candidates, and we have a few starting up here in the next few months, did ask me about how this works. Now, we do not allow our employed, meaning the physicians coming right out, to do concierge medicine. And I'll dovetail us when we talk about that further, is you have to have an established practice. You have to be established in the community, and the physician has to have a sense of respect from the community as well as their patients to be able to fit into this model. So you need a little bit of a ramp up, but I know that getting back to the recruitment piece, they were very interested in that aspect, that once they became a partner in the medical group, which was about 2 years, they would have that opportunity. And again, within the organization, you can remain in or out. No one's forcing you to do concierge. It's a choice for you. It's also a choice for the patients. And I always say too, with respect to the patients in concierge medicine, and this is important, and most of us flew here today, right? I flew from California to Chicago. I paid a little bit extra to have a little more legroom and to be able to get my carry-on up so I wouldn't have to check it through. There's a little bit extra comfort there. I'm on the plane first. But that pilot had to take off from Orange County and land in Chicago safely. And that meant every soul on that plane from first class and so that as a doctor, I don't treat a patient differently with respect to whether they are concierge or non-concierge with this hybrid practice. I treat them equally in that regard. However, the patients don't have to call the call center to get an appointment. If I'm booked up, they're not going to go into Access Clinic. They're going to be able to see me. They're going to be able to talk to me. So for patients, it's a choice. And I think for the physician side, getting back to the recruitment and retention piece, I think it's key as we're having difficulty recruiting primary care, that we have the ability to have a program like this for those who choose it. And retention as well. I had a doctor that was going to leave, but at 2 years, but I told him he could, because he had good quality measures, he had good patient stats, he had good productivity, and he stayed.
So what makes these programs unique is that they're flexible, especially the hybrid programs that you guys have in your organization. So patients can either join or they don't have to join. So the flexibility is key. How do the patients feel? Can you speak to that first, Tim? Like how your patients are reacting to the option to join a program or not? Are they happy they have a choice? What's their experience?
Yeah. So initially it was interesting. We even had some physicians, we do some internal marketing where you'll have brochures, and some of the physicians were like, I don't think I really want the brochures out in public. And you're like, well, I don't understand how you're going to build a concierge. You're going to hide it.
Drawers.
Correct. But we had that. So we had some folks like that. We had some patients that at first were a little offended because we did communicate that we were going to start offering this type of program. And I think really what turned it around was communication and hearing from your physician, look, nothing's going to change between the two of us. It's just that there are certain patients that want to have like an executive physical once a year. They want to have my cell phone number in case something goes wrong after hours, and they're willing to pay for that. And in turn, I'm able to have less of a panel so I can focus, spend some time with those folks with the panel that I have now.
Yeah, I think, from the systems I speak to on the regular, like daily, it's never about taking away in exchange for this, right? So there's an expectation of the experience at Mission Heritage or at Weill Cornell for all patients, but some want those extras outside of what insurance covers, what the typical need is. And those that are in need for those things that are kind of extra and outside of that, they can still get that without leaving the system they like or the doctors that they like. And I think tying together some of these things so far, it's patient option, right? So every one of the systems here, like you're not solo in your community anymore, right? There's a lot of competition. So from a patient perspective, if they're looking for this and you don't offer it, they'll look somewhere else. From a physician perspective, if you're not allowing them to do it like Tim ran into from this other organization that didn't, these doctors gravitated right over and said, well, they're going to allow me to do this. And, that recruitment happened in that way. And so it's serving the community of patients and physicians and the desire for that. And that's current and proper and active. And it's not a new concept. And it's not just New York or Orange County, California. We do work in Guntersville, Alabama, Derby, Kansas. Anyone here any of those places? So this isn't just like, oh, it's a Dallas and LA and New York City thing. The conversations are kind of everywhere because patients have a desire for this, physicians have a desire for this, and systems have an opportunity for this as well.
Yeah,
So-
and I would just add, I'm sorry,
Go
the
ahead.
patient satisfaction is incredible, very, very high. And Concierge Choice does sort of a 6-month check-in with those patients once they sign up. There's a survey, I think, right? I think you send a little survey to say, hey, how was your first 6 months? A couple of questions. They get the information, and then they'll meet with me, and we'll review that to make sure did that patient actually get their executive physical already? Do they feel like so far 6 months in that it's worth the membership fee? Really good information.
And I think also just on that, and I'll take from Chad because you've said this before.
Yes.
It's one of those, and I always mess up the phrasing, the rising tide raises all ships. Because Chad has mentioned to me the satisfaction scores from non-members is also increased, right? This isn't a concierge members feel this heightened great experience and the others diminish. It's kind of like everything kind of moves along because there's just a change in like the overall feel and engagement that happens. Is that accurate to what you've seen?
I mean, we were keeping track as we were piloting the program. We were keeping track of, obviously when we first started out, the physicians had to be top notch, right? High patient sat, productivity had to be at 60% MGMA, and they had to be obviously willing to do it. They did it. And what we did is we were monitoring, did the concierge, adding the concierge decrease their productivity? The answer is no. Did it decrease their patient satisfaction? As he pointed out, it went up. And I think that's a recruitment tool in and of itself for your concierge program, is that the other patients know you're doing it. And then really, I attract more patients. I mean, they obviously send out some flyers and stuff periodically, but majorly speaking, it's the patients in the room say, you know what, Dr. Waddell, I know you have this concierge program. I think it's a fit for me at this juncture of my healthcare journey. And that's where you're meeting people. And again, it may not be right for a patient now, but it may be right for a patient 5 years from now, 10 years from now, but they know it's there and it's an option for them. And it's worked well.
So we talked a little bit about physician retention and recruitment and physician satisfaction and patient satisfaction. Let's talk a little bit about revenue. And can you talk a little bit about how you used concierge medicine as an opportunity to increase revenue streams, enhance revenue streams in your existing organization?
Yeah, so sure. So for us, as Chad mentioned earlier, primary care is usually subsidized. So in our situation, we get a subsidy from New York Presbyterian Hospital, which is our partner hospital, really for the expansion of primary care, and then through the school, Weill Cornell Medicine, for sort of, subsidizing the bottom line, if you will. And since we've done concierge medicine, that subsidy has reduced basically every year. And so there's potential probably within the next year or two for us to not require a subsidy, which is huge. And then to take some of those dollars and do something like build a Medicare program and fund that program, because currently we can't afford to do that and we really don't have interest from either of the other parties. So the dollars are real dollars, and they not only help the physicians that are getting their portion, but the department as well.
Keith, maybe you can answer a little bit about,
No, go ahead, I'll go.
Tim mentioned about the real dollars. Like, can you just explain a little bit about a hybrid program?
Sure. Yeah, so again, everything's always in conjunction with insurance, so this isn't like a separation and you're dismissing it and then supplanting with. So every engagement with a concierge member is a plus to that bottom line. And as Tim mentioned, those dollars tend to get used in a share with the physician themselves. So the physician providing this extra layer of service, this extra availability, has some financial benefit for doing that, right? They're delivering the engagement. The patients aren't joining for the generic nature of a concierge program that exists somewhere. Chad's patients are joining for the relationship with Chad. And so the physicians have a benefit to that, and that engages them. And then similar to like what Tim said, that idea that these dollars go to overhead, they go to expansion of other programs in the community. It's always like the charitable part of doing this, those that can contribute, and those dollars in turn can expand and spread to others. And every system we've worked with has seen a nice uptick in that revenue, which again, I don't see insurers ever turning around and saying we want to pay you more and more every year. It's more and more patients jammed in to kind of get to the same dollar. So this kind of takes it to the side of that in conjunction with it and kind of adds that. So you actually have an opportunity for revenue that can increase over time. It's a reimbursement that you can increase, not getting compressed.
I concur with Tim. I mean, the primary care is a loss leader, as we say, but again, the investment down the line is gigantic. I mean, one internist or one primary is generating probably over $1 million in revenue down the line for each patient life, just from consults, surgeries, and whatever is being done within your hospital system. But nonetheless, anything that can subsidize this, we had minimal overhead increase. We had to have basically a concierge medical assistant that would and a dedicated phone line and honestly, most of the time they're going to just text me or call me and say they need something. We are able to have one MA, for like 8 doctors right now. That's where we're at, but it's a minimal increase, and we collect so much money, and then a portion of that goes to the organization system, and obviously the majority of it goes to the physician who's doing the work, which again, that leads to less burnout. I think a lot of burnout, guys, is doctors are spending time in the in-basket and they're not getting paid for it, right? And they're frustrated. This allows them to get compensated on top of that. That makes better well-being index when we're following that. And then you talk about the investment that you're getting now, that in primary care doesn't have to be as much of an investment. It's better for the bottom line. So it's a no-brainer.
And so, Keith, Dr. Waddell and Tim discussed how they began their concierge choice programs and how they're working and how they grew from there. Can you just touch on what does it take to get started? That's always the hardest part, taking that first step.
Well, I'll repeat what Chad said. Lots and lots of meetings. I think with each of them and their organizations, there's probably about 2 years of meetings. Some started pre-COVID, so then there was a pause for 2 years. So, time-wise, it was 4 or 5 years. But I think what it really comes down to is every conversation I have starts with we're hearing about this from patients, or a physician left to go do this, or we have patients that are leaving to go to somebody to do this. And I think it's just about starting those conversations and understanding that you can pilot this on a very easy level. I think that's what it's about. There's not a big investment. There's no upfront cost to this. It's not a wholesale change to your medical group, to your physicians. You could take a handful of doctors who are interested in this, put something in place, and test it out. And everybody started with 3 doctors, 5 doctors, 12 doctors, and every single one has grown it every year thereafter. The upfront investment, there's not a lot in healthcare in your systems that you can do where it doesn't cost you a lot on the front end for the hopeful return on the back end of it. And this really is a path where you can walk it kind of for free, let's say, and just build it as it goes. And you could always pivot, right? There's no wholesale change to a practice. A hybrid program like they're doing is an option for patients. And if you ever had a doctor Chad's group had a doctor who started and had to leave for medical issues, you just wind it back down, right? You start it up, you bring it back down. So there wasn't some new problem to solve at a change point for a physician. And I think that's really the key, is that it really is that simple once you get through all the stakeholders and all the conversations. to go, and then it just
Yeah.
builds upon itself.
Yeah, I would add that the other nice thing about it is that it's very individualized. So like I said, I have 20 physicians doing it now. The programs are somewhat different where, all of the things that we offer for all of them, but we have some doctors that have, 16 patients that are concierge patients, and then some that have 161. So you as a physician can decide as you're piloting it how slowly you want to do it, or you may not have a lot of patients that are interested, but it's very individualized. And I think that's a key selling point to a physician when you're trying to pilot something like this.
Okay. Do we have any questions in the audience?
So I live in Florida, and one of the things I'm seeing in our area is that physicians are leaving insurance altogether and just doing what they're calling concierge.
Mhm.
So it doesn't sound like that's part of your program at all, but have you heard folks wanting to do that, like get out of the Medicare business altogether?
Yeah, so we have like independent physicians and like independent medical groups where they're looking at all those kinds of options. But I think what's really wonderful about how we approach it and work with the systems is that this isn't, you don't have to drop that, right? That's still the bread and butter. That's still needed from a patient perspective. They have it from their employer or they have Medicare and they have it and they want to utilize it and have the benefits of that. So you don't have to like strip away that part, A doesn't have to go away for B. And you could kind of have that both in conjunction. And so with the large health systems, it works because the idea of dropping insurances or changing the relationship with insurances that way, I think is, I couldn't imagine that being a internal conversation with legs.
Well, I have to there's full disclosure here. So are you in Boca Raton, by the way?
No.
Okay, so I do have one physician that is out of network in Boca that we started with she's a long-term physician with us, many years, 16, 17 years, who really wanted to relocate to Boca full-time. And so we actually did that model, and it was slow to grow, but it's actually getting there. Mm-hmm. We couldn't afford to put her there and accept Medicare. Yeah.
Chad, can you speak a little bit more on logistics of how you reached that 150 cap for hybrid model? And then what is the other regular panel size associated with that 150?
Thank you. Thank you for your question. So initially it was 100. We said, let's see how 100 goes. So when we piloted with the first 5 physicians, it was 100 patients. With respect to panel, we were talking anywhere between 2,200 to 25 to 28 on the specific physicians. When we got to 100, we again, at this point, the system was more in favor of us adding on more patients. So it was rather easy. Conversation, we're like, hey, we're doing okay at 100. It feels okay. I think we can push a little bit more. So a few of us decided to go for it, myself included. And I would say, and this is, anecdotal, my own experience, if you go in that 150, 160 range is probably your push with that. I wouldn't go past that. Otherwise, you're not providing good care to everyone. So that's about your cap. But that in realization is, hundreds of thousands of dollars to the physician and to the organization, at least in our model, per doctor. And it's working. Again, we looked at productivity, benchmarks, and they have remained the same. Our patient satisfactions across the board, our concierge patient satisfactions are outstanding, and the satisfaction scores within all of our panel have remained at or above where they were. And again, getting back to the burnout aspect, there's a portion of this that you kind of get back to the heart of why a doctor's a doctor in helping people and having the time to do that. And concierge gives that to the doctor. And I think there's less burnout on our, I don't have any burnt out concierge doctors.
And I would say just on that operationally, a simple math setup for that is 100 members is about 1 hour per day set aside for concierge, right? So the rest of the day, you can think about the majority of the day is for traditional patients. in the same way that it's always been. And as Chad mentioned before, and Tim knows with his physicians as well, you set aside that hour, and whatever the language is you use in your system, right? You freeze it and then you thaw it.
Yep.
It's just set aside if it's needed, and if it's not, you backfill, right? So these aren't like lost hours, and even if the hour is set aside, it's prepaid for in the concierge dollars, structurally for the physicians for productivity. Typically, an RVU, a WRVU is assigned to that. That's appropriate for that, so nobody gets dinged on their productivity or other goals that they have to meet at the end of the year. But the math is kind of straightforward in that way, and like Chad said, so he goes up to 150, and I agree. In a hybrid program where you're seeing a healthy panel of, let's say, 1,800 to 2,200 patients with a portion of them concierge, after about 150, you could be pushing the max. We have folks who go up to 200, but they're looking to put 4 or 5 kids through college, pay for weddings, and they're workhorses in that way, but it is not recommended. And from our side, all the work we do on the front end and the analysis, all the things that we do before we even go to launch a doctor with any of our clients, kind of map that out, look at where it is, and like Tim and Chad said, set a cap that makes sense. You could always grow from there. And like Tim said, we have a doctor right now, one launch, has about 20 members, and is happy that they want to dip
They
their
want to
toe
stay,
in
right.
and work that way. And then others that were like, I'll take every single member I could get. I am ready for that. And they're the right people for that. So it works. But it's not one size fits all. Even within the same office, the same doctors that are grouped together, they have their unique flavor to it.
Yeah, I would just add, we do have guardrails though. Like,
Yes.
so the doctor doesn't just say, I'm gonna take on 200 concierge patients. We have a young cap, a 50 cap is what we would start with. Everyone that has wanted to go above that, we have allowed, but we really monitor that there is no negative impact across the board. Just again, and the one thing that I'll just add is if you're interested in this, the CMO and myself made all the decisions in the beginning. It's really better if you create a committee of physicians, which has been super helpful. Of the concierge physicians, I think we have about 5 or 6 now that are senior physicians that really help us to make the decisions and then, bring it out to the broader group.
I think there was another question here. Yes.
What does the payment structure look like on the patient end? Do you guys allow like tiers? Do you guys allow them to do monthly payment, or are they forced to do annual?
So the general stake in the ground is don't create tiers upon tiers from a patient perspective. The engagement for these things outside of what insurance traditionally covers. I have doctors who say, oh, well, I'm going to include these tests in this, and then this is going to, and from a patient perspective, they don't know what those tests mean. It's like they're a consumer now, and they're going to assume that if these tests are valuable, insurance doesn't cover it, and you think these are valuable, you're going to do these for me, not say I'm only going to do these 3 for you unless you pay the next gateway. So I always say it's a price for the availability, the participation, that kind of engagement. A single price tends to work. From a payment perspective, we offer patients the options from annual, semi-quarterly, and monthly, but the engagement's for a year. But the idea of having the flexibility and the payment frequency is for the patient perspective of fitting it in their budget. So it's not only the people who could pay annually or have their Amex that they could throw it on, get to join, right? Some people budget for it monthly in their paychecks, and you'll be surprised when, we always have those conversations. The person who pulls up in their Bentley and then their Ferrari on the weekend, they're not the ones that join. And sometimes it's the folks who you don't think can necessarily put that all together. They really value their healthcare in that way, and they're going to make that decision in their budget. So that flexibility, the analysis we do for pricing to find the proper pricing is all about making it accessible to the patients that are in the community that practice is serving.
Okay, and we have another question here.
Thank you. This has been so interesting. I really appreciate it. Following up on what you just said, I'm very curious about the demographics. Is it older people? Is it chronic conditions? What do you think?
So
I think
typically,
Chad,
you want to speak?
Yeah.
Sure.
Dr. Waddell, you want to?
I can answer that, and
Please,
you can
go.
answer that. It varies. You have some younger people who just are really, really busy, and they do not want to deal with anything other than if I got a problem, I want it solved. So you have that demographic. Then you have, I would say, I call it my executive, probably people in this room who are extremely busy and they have meetings, they are running a business, they need to get in, out, done, finished, right? Those people. And then you're absolutely correct. The majority of patients are elderly and have chronic conditions, and a lot of them want you there for peace of mind. Know that they can call their doctor on call, and they're not going to be calling someone who's covering me per se. So that is the majority of it. But it surprises you. You would think, the more affluent patients, not necessarily. I mean, obviously there's a smattering of that, but it's mostly people who honestly, it's for the physicians in the room, it's the people you really, really connect with that you'd probably even go out to lunch with if you could as a doctor. This guy's a cool guy. Hey, how was your trip to Europe? Whatever. And these are really, the people you really connect with are the ones that sign up. And it's, yeah.
Statistically, it tends to be 50 and older, more specifically over 65, juggling one or more health issues. I always say, everyone wants, the younger bodies that are going to come through it. And again, some of it's convenient, some of it is just their expectation of on-demand everything. But when people think about health and wellness and membership and they're in their 30s or 40s, they're joining Orange Theory or CrossFit or Barry's or whatever the new trendy workout trend is, right? We fall into that trap. I'm always of the, I didn't feel well, so I just went to the gym. I threw around more weights and went on, did some cardio. And then you hit a certain threshold where you're like, yeah, that doesn't work anymore, right? It's really more of a medical need. And so it tends to be that Medicare age tends to be the bulk of members across the country in all areas. But Tim has communities on the Upper East Side of New York City that just...
It's interesting. It's a great question because I thought when we first started it was going to be that demographic, the Medicare demographic. It's also dependent on the physician, their panel. So if I have a guy that's out 5 years, he may have a younger panel just because he's younger, and those folks will join as well. Mm-hmm. So it's really very, very interesting. And then I have senior physicians that will say they've become older with their patients, and the majority of their patients that are concierge are Medicare or above. Yeah, so it's very interesting. Ms. Delacari.
High level about the type of support that Concierge Choice offers to help launch a pilot.
Yeah, they've been great partners, otherwise I wouldn't be up here with them. What they really do is, again, like Keith mentioned, Chad mentioned, the meetings are incredible, as we all know, in academic medicine. And so just by coming in, explaining what the program is, helping to get the buy-in, helping to modify the program as much as possible. We did a lot of modification. Mm-hmm. And then sort of taking the ball, and they train your team. They physically send people to New York to sit with your team 2 weeks before a go live. They're in the practice. They get to know the nurses, the MAs, the practice manager. We give them a section so that they can very discreetly, if you will, recruit patients, right? If physicians say, hey, I'm going to start this program. By the way, Mary's here from Concierge Choice if you'd like to speak with her. So they give you that kind of on-site help in the beginning. There's marketing. They do an assessment of your panel. You give them the patient data. They come back to you and they say, okay, these 6 physicians that you think should be doing concierge medicine, here's the breakdown or the profile of each one of them. And it helps you to decide, hey, do we move with Dr. X or not? Their numbers aren't in sync the way that we think it would be a successful program, we'd probably put that one to the side. All of these types of things, the 6-month check-in with the patients, we have meetings every 2 weeks with our operations team to talk about, the new physicians that we're thinking about, how things are going with the current physicians. So I would say we have I literally have everyone's cell phone number here. So we are in communication constantly. Very supportive.
Yeah. I would echo, he was able to help me as we were trying to get it integrated from a perspective of exactly what Tim says is they analyzed our patient panels for do we have the right demographics? Check. And then really they went and did the marketing, for us, and they allowed us to really. There was a lot of feedback back and forth, especially how the system wanted it going out and communications going out. They were very malleable with that, and they've done a great job in every month. Our patients get newsletters from us. They do that. They'll do more marketing campaigns afterwards. They handle all of the fees that that they collect, and they just send us the check, which is rather easy. So it makes it a lot more simple and something outside of our organization that has to be run by our organization. So they do a great job.
That's
And I would add,
probably
if I
a
can add one more thing. to that.
okay.
Just because we just did this recently with another system, I won't name them yet because they're not active, but they had us look at they have 120 primary care physicians in their medical groups. We did an analysis on all 120. We were able to put them in like quarters. So they took that first top quarter, the first 30 physicians are the ones that they're looking at. They're doing the analysis, doing the survey to see who would be part of that pilot group. And right now we're at a phase, and I think it's going to be 12 to 15 of them are going to be in the pilot. Some of them, it's just, they qualify for it, quote unquote, but they're not like, they want to see what their friend does first and how that goes. They don't want to be the first ones in, right? So you have people in all those aspects.
I think that was a really good question to end with. So I have to wrap this up a little bit. But if you have any more questions, we are at booth 224, and we'd be happy to talk with you a little bit about our programs. And I'm sure you'll see Tim and Dr. Waddell wandering around. I'm sure they can answer any questions as well. So stop by and see us.
Thank you.
All right, good.